Hello everyone, welcome to the outcome of the clinical case from this week. It's a 4-year-old male-neutered boxer that presented with 5-day history of abnormal eye. Physical and neurological examination revealed this dorsolateral static strabismus on the right eye. He had internal and external ophthalmoparesis on the right eye with decreased direct and indirect PLR on the right eye. So the first question is, where is the neurolocalization? If we have an static strabismus, it's an abnormal position of the eyeball relative to the orbit. So one of the structures that contribute to the position of the eyeball relative to the orbit are the extraocular muscles. This is just a summary. If you remember, there are 4 rector muscles, and they are named as dorsal, ventral, medial, and lateral. And we also have 2 obliques, the dorsal and the ventral oblique. There are 3 cranial nerves that innervate the extraocular muscles, which are the oculomotor, the trochlear, and the abducens. A way of remembering is to abduct the eye is to move lateral to abduct. So the muscle that the abducent innervate is the lateral rectus. It's a way of remembering. Trochlear is like a pulling system, so in order to make the pulling system movement of the eyeball, it has to innervate the dorsal oblique. The rest of the muscles are done by the oculomotor. So it's a way of remembering rather than remembering that the oculomotor does the dorsal, the ventral, the medial rectus, and the ventral oblique. So if we go back to our case, it has this abnormal position of the eyeball relative to the orbit, and it was this dorsolateral strabismus. So in order to have this static strabismus, because in this case, due to a lack or a dysfunction of the oculomotor nerve, because we have atony of the muscles that the oculomotor nerve innervates, which is your dorsal rectus, medial rectus, ventral rectus, and ventral oblique. And also remember that the oculomotor innervates the levator palpebralis superioris muscle. So sometimes we can see when there is a oculomotor neuropathy, a degree of ptosis when we evaluate the upper eyelid. Other clinical case that this dog presented with was a dilated pupil, that this eye was visual, so had normal Menas response. However, it had a decreased pupillar reflex. So the normal innervation to contribute to the pupillar reflex, we have to evaluate the parasympathetic innervation to the eye. So a way of doing the pupillar reflex, we have the stimulus with the eye. That stimulus is detected by the retina, goes through the optic nerve. At the level of the optic chiasm, particularly in dogs, 75% of the fibers cross over, and then those fibers becomes as the optic tract. Because we're not evaluating the vision at this moment, we're evaluating the reflex, that axons or those axons will synapse at the level of the pretectal nucleus. It will cross over through the caudal commissure, and the same fibers that cross at the level of the optic chiasm, pretty much the same fibers cross over in the caudal commissure to innervate or to make a synapsis, to the oculomotor nucleus. And this becomes your preganglionic neuron. And this preganglionic neuron, the axons, form your oculomotor nerve, which is gonna synapse to the ciliary ganglion that contains your postganglionic neuron, which in this case is the short ciliary nerve that contributes to your direct PLR. The rest of the fibers will remain on the contralateral oculomotor. In this case, around 25% of fibers in dogs will synapse at the level of the oculomotor nucleus, becoming your preganglionic neuron. It synapses at the level of the ciliary ganglion with the postganglionic neuron, giving the short ciliary nerve, which will contribute to your indirect PLR. As I said, remember, this is a reflex, and therefore everything happens below your thalamocortex. So if we have to put all together in this case, also if you have a normal vision, and remember this dog had normal postural reactions, it didn't have any other alteration on the mental status, so therefore it's very unlikely we have a brainstem lesion that will affect your oculomotor, and we don't have any other clinical signs associated with brainstem dysfunction, as it could be postural reactions, mental status. So in order to explain this absent PLR with normal vision and then the rest of the neuroexam apart from the static strabismus is pretty remarkable, we need to think about a lesion affecting your oculomotor nerve. Putting everything together, so this 4-year-old male neutered boxer with 5-day history of oculomotor neuropathy, what are our differentials? So mainly inflammatory, infectious, or vascular, because there were not obvious signs of being progressive. However, we only have 5 days history. So I strongly recommend that you watch the video from Fraser McConnell, where we explain, or he explains the MRI findings in this case. So the MRI findings describe the enlargement of the right oculomotor nerve, where there is abnormal contrast enhancement on the right oculomotor nerve with the adjacent meninges and perineural tissue, and there were also mild atrophy and increased contrast enhancement on the extraocular muscles, and mainly on the visual, on the medial rectus. If we talk about the differentials, we could talk about the oculomotor neuropathy, the idiopathic underlying cause, inflammation going for neuritis, or neoplasia going for lymphoma or other meningeal diseases, including the beginning of a meningioma. Remember that the middle corneal fossa, there are different structures where unfortunately neoplastic cells can arise from. So in this case, we started immunosuppressive treatments, thinking that potentially could be a neuritis. The dog did improve, what the owners reported being back to normal after 6 weeks on the eye appearance, and the neurological exam was considered normal at that time. How do we call this? Do we call this oculomotor neuritis because it did respond? What happened if we wouldn't have given anything? It would have responded as well. We don't have an histopathology, so call it itis. We cannot really, because we didn't see any findings on our tests that were consistent with inflammation. And interestingly, we saw several cases. We put them all together in this in this paper, where we didn't find an underlying cause, and they got better, and many of them without any treatment. So this is another example. This was a Weimaraner where he didn't had any treatment. We did a follow-up MRI after 2 months, and this enhancing lesion disappeared. So when we talk about this idiopathic oculomotor neuropathy that we reported in 14 dogs, it's important to remember that when we suspect clinically about this idiopathic oculomotor neuropathy, the clinical signs are only associated with the oculomotor dysfunction. So if you see any other neurological deficit that is not due to oculomotor, this does not fall in the category of the oculomotor dysfunction. The MRI changes are only detected in this area, and they have a good prognosis because they either stay the same or they improve. If there is any clinical signs of deterioration, altered mental status, other of the cranial nerves that runs through the middle cranial fossa affected, then we are not talking about this idiopathic oculomotor. So it's very important to monitor these dogs, that they should not progress. And we try to evaluate the same in cats. What happened with cats have this idiopathic oculomotor neuropathy, and it's very rare that cats present just with oculomotor neuropathy. And what we saw is that cats with, in this case, internal ophthalmoplegia and other intracranial signs had guarded prognosis. So it's more possible that there is an underlying cause in these patients when we talk about cats with internal ophthalmoplegia or clinical signs or oculomotor neuropathy. Hope you find this case interesting, and if you have any question, please ask, and we will be there to answer. Thank you.